the closure of the Hammersmith EU. I'm going to just give a sort of brief overview in terms of our state of readiness around that and ensure that the board has time to then ask questions, and I'll be running through these areas in terms of giving that assurance to the board. So firstly, really just to state the current state in terms of how our three emergency departments, emergency units are organised. I really, from this slide, just want to pull out the position around the Hammersmith emergency unit. So the Hammersmith emergency unit does not comply with the standards of a full emergency department. It is not staffed with emergency practitioners at consultant level and does not have emergency practitioner trainees associated with this department. So there are significant limitations in terms of what the Hammersmith emergency unit can actually provide in terms of its current arrangements. Just to give some sense around the anticipated activity flow, I think it's really important to pull out from this slide two key points. Firstly, that we do have UCC already on this site. We're extending the availability of the UCC from its 12-hour position to a 24/7 UCC. So we are anticipating that the current levels of attendances of patients into the UCC will not only maintain current levels, but will also increase in terms of the provision that's available overnight. We are making plans to ensure that we are ready to accommodate the movement of patients who would otherwise then need to be treated in another emergency department, and we're focusing that effort on ensuring we have resilience at St Mary's. And you can see that we're anticipating up to 60 patients a day that would need to be treated at St Mary's against these sort of areas in terms of ambulance arrivals, walk-in patients or transfers from the UCC, with up to 13 admissions a day. And this is the upper level in terms of our areas of risk. We are anticipating through a number of the measures that we're putting in place that will be less than this, but we are planning for that level of activity that would need to be transferred in terms of patient attendances, particularly at St Mary's. What you'll also see is we're not only just focusing on St Mary's, but also focusing on our resilience at the Charing Cross Hospital site as well. Just very briefly, in terms of the drivers for change, you've already heard Tracy talk about the clinical strategy and some of the wider changes within the healthcare system. I'd like to really draw out the third bullet point on this particular slide. That last point is really key about the sort of clinical position within our emergency teams around the safety issues to do with the Hammersmith EU continuing. This is not a new issue. This has been an issue that we have needed to face for some time. The downgrading of the Hammersmith from an emergency department to an emergency unit happened a number of years ago, and the current staffing model is not with emergency department practitioners, it is with acute physicians, and we do not have emergency practitioners in terms of registrar and junior training numbers staffing the emergency unit. We have a high level of locum and agency staff needing to staff that in terms of the junior medical grades. Anything up to 40 to 60% of our cover at that junior medical staffing level is from locum and agencies, and we are not able to fill that rota safely and consistently going forward into the future, and hence why from Imperial's perspective, focusing our emergency department efforts within the Charing Cross and St Mary's is absolutely a clinically led safety issue for us that we have been working towards. If I just take us on to some of the governance arrangements around how we've been developing our plans around this, I think the key message from this slide is that there have been absolutely strong internal governance around executive and senior clinical leadership in terms of the planning for the Hammersmith EU closure and our preparations around that. And that is directly also linked in to the wider governance arrangements within the CCGs and within North NHS England in terms of not only the Hammersmith EU closure, but also the implications for the closure at Central Middlesex. And the reason why we have moved towards the 10th of September is because that is when both of those units will close, and they will close at the same time, so we do not have an implication of additional activity of patient attendances, either going to Central Middlesex or the Hammersmith EU if either of those units close independently. So we've had very strong governance, very strong clinical leadership over the period around these arrangements. I just want to touch on some of the new clinical pathways, again, that has had strong clinical leadership and drive within this organisation, and also working with our CCG colleagues and with GPs. So the new clinical pathways for the Hammersmith EU will be centred around maintaining and strengthening the current clinical pathways around GP referrals directly into the Hammersmith hospitals, acute medical and medical bed base, and also ensuring that we can again continue and maintain the specialist referrals that currently come in to the Hammersmith into our range of specialist services, and that will include the Heart Attack Centre, which will continue to receive the referrals directly from the London Ambulance Service that it does now, and with no changes around that, and equally no changes and in fact strengthening of the arrangements around our renal specialist referrals, haematology being two other areas. In terms of a little bit more detail around that, so to support that, we've introduced a medical referral telephone service to act as a single point of referral. So across the whole of our organisation, we can make sure that any GP referrals that require an urgent admission into one of our acute medical or specialist medical beds can be managed rapidly and effectively, and we can use our inpatient urgent and emergency capacity across all of our sites. And so we're making sure that we are directing patient admissions from GPs rapidly into the right location. And again, as part of these changes, these are some improvements and developments that we are making in the way that we're managing the emergency and the urgent care pathway. Just in terms of specifics around Hammersmith Hospital readiness, I think the key message from this slide is that we are already starting to open and develop that capacity. As you can see, that the UCC has already opened from the 23rd of June to 24/7. We are working with UCC colleagues around the skills and training and support that they require as a standalone UCC from the 10th of September, and we will continue to provide that support over that period. We've also opened other elements, or will be opening other elements of our capacity in the early part of August, so we start to run the additional capacity on the Hammersmith site ahead of time. I think I would also just like to pull out from the last couple of slides that we're using this as an opportunity to change the models of urgent and emergency provision. So we're increasing across all of our sites the capability for ambulatory emergency facilities. So as we start to allow hot clinics, so hot emergency and urgent care clinics, as well as ambulatory emergency provision, to really focus senior clinical attention to patients to avoid hospital admissions and to manage patients rapidly in an environment that does not require them necessarily to be admitted to hospital. And that is some of the important changes in clinical care that the organisation is looking to drive through our clinical teams. In terms of St Mary's, so a lot of focus on whether or not the site at St Mary's is able to deal with the additional patient flow and patient pathways onto that site. So two key sort of areas just to highlight here is the physical capability and capacity that we have put in place that also again allows us to manage emergency pathways and urgent pathways more effectively in a different way. We have increased the physical capability and capacity around our ambulatory emergency pathways on the St Mary sites. We've increased the physical capacity within the emergency department, both in terms of the resus spaces and the spaces within majors. And we've also increased the staffing levels within that emergency department, both in terms of core medical trainees, specialist nurses in terms of our emergency nurse practitioners, and also over the course of September to December, we've now approved a case to recruit 6 additional consultant emergency practitioners into the St Mary's emergency department, which will extend the cover at consultant level up to midnight on the majority of days during the week, and with additional consultant cover over the weekends. Charing Cross, as I said, is an important location in terms of our resilience as well. So we're not just focusing on the likelihood of additional patient activity and attendances going to St Mary's. We're taking this opportunity to similarly increase the resilience of our emergency department at the Charing Cross. Again, just to focus a few areas from this particular slide. So again, we've taken the opportunities to increase our services for older people, our OPRAC and our OPAL services, so we're able to further look at the integration that Tracy talked about around our frail elderly services between the front end of the emergency department and integration with community and primary care. And we're also able to increase our ambulatory facilities for emergency medicine at the Charing Cross as well. And you can see a number of additional staff in terms of trainees and nursing staff also going in to support the emergency provision at that site.
The 22,000.
Just before I conclude, in terms of our statement of readiness, the paper that accompanies this slide presentation in the pack also talks about the communication plans that we are working jointly with commissioning colleagues around, and we would be happy to take questions on that. And also the paper identifies 2 residual risks within the position that we've mitigated many of the risks that we presented to the board at the end of May. The 2 final risks around our intersite transfers that we will need to have resilience around to legitimately move patients from St Mary's to, say, the Hammersmith to a specialist bed environment. We're working with our emergency transport providers, so as by September we will increase the provision of 24/7 transport facilities for patients that will need to be moved between sites. And also the performance risk in terms of our 4-hour waits. And again, I'm very confident that the measures we put in place at St Mary's and at the Charing Cross that I've identified mitigates that risk adequately. So finally, Chairman, I think we are in a position to recommend that the Trust Board does endorse the planned closure of the target date of the 10th of September.
No, that's got to cover 22,000 patients.
Could I just ask you to comment on